I just want to say I hope people are well. It's a very unusual circumstance we're living in, and it's caught a lot of people by surprise, and it's affecting the world in a kind of a extreme way. So we're having to adapt to the circumstances. One of my professors said that the key feature of mental health is the ability to adapt to the circumstances you're in. So part of this adaptation that we're having to go through quite abruptly is doing so much of our work online. And the good news is that it's surprisingly easy. I've been doing it for a long time because of various characteristics of my practice, but I've been speaking with colleagues who just started really in the last week or two, and they're pleased to see that it's working out well for them. And we're very fortunate in our field as psychotherapists that we can continue our work under these circumstances and help our patients because they need our care very much. And one of the issues I'll discuss later is the challenge of beginning with new patients under these circumstances. But the main thing about the online work is that we have to be very attentive to paying attention, as we always do in psychotherapy, to the treatment frame. That is, what are the conditions of treatment? How do we define them? And how do we discuss them with the patient? And what is the role of each person in the interaction? A lot of that is the same as it has always been, but some of it is a little bit different. I'll go into that later. Just historically, I've been doing treatment at a distance since the 1990s, when some of us actually began to do therapies on the phone. This was usually cases, in fact, at that time, it was always cases where we had begun the work face to face, but if the patient moved and it seemed like a good idea to continue with the same therapist, we could move to phone work. There were a few articles at the time about this, but not much of a literature. Then in the 21st century, people began to work more online. Initially, it was more about teaching and supervising rather than treating patients. But there's been a lot of experience in China in particular, where in the desire of a group called the Chinese American Psychoanalytic Association to begin to help the Chinese learn about psychoanalysis, they started doing both the teaching and online psychoanalyses, and we have benefited from their experience. But now, of course, the situation has changed. At that point, the goal of online teaching was to extend our work to areas where there were not people present who could do it. Now it's just to allow us to continue our work when we are not able to see our patients face to face. And as I said earlier, this is a time when our patients need therapy. To imagine somebody with a severe mental illness now faced with isolation and detachment and the lack of contact, it's extra stress on people who already have trouble tolerating stress and dealing with stressful situations. So, what are some of the practical considerations? First, to have the appropriate technology. In the past week or two here in the United States, people have been trying very hard to find the right technology. Having said that, our governments have sometimes now been quickly adapting to the situation. Just as of 2 days ago, there's a new regulation here which makes it easier to do the online work. Specifically, even though online psychiatry has been authorized for a while here, there was a rule that you had to have the initial session face-to-face in the office if you were going to prescribe a controlled substance, a substance that had an abuse potential. Just as of 2 days ago, the government authorities, the DEA, has said now the initial contact can be online. You're not required to have that face-to-face contact. But you have to be aware of what the regulations are in the jurisdiction in which you're practicing, because as much as we want to help our patients, we also have to be careful we are not putting ourselves at risk by violating the regulations within which we practice. But getting to the more clinical considerations, I was going to talk about this frame of treatment. Now, if you do any form of therapy, you have to think, how do you describe the conditions of the treatment? And I'm not going to resume or some for everybody. Everybody has their own model of treatment. But there are certain things we've been thinking about as we work with our patients. And it depends, of course, on the type of patient with whom you're working. In my practice, I tend to work with a lot of patients who have personality disorders. And along with that condition, there's the risk of acting out. So we're all concerned about how do we deal with that at a distance. If somebody's in our office, I'm talking about situations that are rare, but in emergency times, the rare situations have to be thought through. Suppose I'm in my office with a patient and the patient seems like they're at risk of suicide. In my office, I would call an ambulance, have them taken from my office to the hospital. If you're seeing them and they're somewhere else, you have to think ahead of time, what do you do? So first of all, we find it's important, even more than before, to have an emergency contact. Who is the person to call if you have a concern about your patient? Make sure you have a name and contact information to whoever they would list as their emergency contact. Secondly, be sure you know where they're calling from, because patients can call and then after the fact, you might realize you're not sure where they are. You don't know what address they're calling from. So you need to know the specific place they're in. Suppose you had to call an ambulance, you have to say where the ambulance should go. So those are some emergency considerations. After that, I'm just going to talk about some of the experiences we've had that we have learned from. The contact online is unusual. There's a kind of an odd closeness, like if you're seeing this, Ilaria and I are right beside each other. So we have to make sure we continue with our professional demeanor, our professional presentation. So part of the frame in the online work is to say to the patient, we're going to meet and make it as much like being in the office as we can. I'm going to sit in a chair. I expect you to sit in a chair and to be dressed as though you were coming to the session. I'm saying this because in our brief, more frequent experience, some of the new therapists who haven't done this before and who haven't set up these conditions say, you know, I had the online session begin and they're lying in bed, they're sitting in bed, it's very uncomfortable. So part of the frame is this is still a professional encounter. Depending on the type of pathology your patient may have, they might want to get closer in a personal way. They might want to test the limits of how kind of cozy and comfortable and informal it might seem. You have to keep up the formality of the interaction. We've also found, this seems like a small thing, but if you look now at Ilaria, she's very close to the screen. We actually recommend that each person sit a little bit removed like I'm doing. It seems more like what you're doing in the office. It doesn't seem like you're talking to a friend on FaceTime. So an appropriate distance is helpful. Of course, in psychodynamic or psychoanalytic therapy, we're very sensitive to the nonverbal communication. There is still a lot of nonverbal communication in the online contact, but it's different. You don't get the whole body language. It's more a matter of the facial expressions. So it's more of a challenge to be adequately in touch with the nonverbal communication. And at the beginning, the interaction can have a stilted quality where the people don't feel comfortable and natural, usually that goes away with time. Now I'm going to end, and then Ilaria can ask me a couple of questions, but I just want to say that the nature of the online sessions has, as I said before, to do with the type of pathology the patient has. So many patients experience this effort of ours to continue the treatment under the unusual circumstances. They experience that as something that they appreciate. It's a sign of our commitment to them, and it actually can help build the therapeutic alliance. But if patients are have a psychological makeup where they tend to have a paranoid stance toward the world, they tend to have insecurity in their attachment, they tend to have rejection sensitivity, sometimes we find that we have to work on that as we would be working on it anyway, but now with certain aspects of the online situation that might feed into the rejection sensitivity, the paranoia. You don't want to see me, you're afraid of me, you think I'm toxic, and you have to deal with all that the same way you would if you were in the office, because they will be the same themes, but now with a different specific content. But overall, we believe that doing this, expressing and communicating in a subliminal way, our authentic interest in the patient, our commitment to their treatment, is a message that patients will appreciate and will be reassuring to them in these stressful times. I was having an online session with a patient who I had been meeting with in my office, as is the case with most of my patients. And I saw that he was outside, and I said, could you tell me where you are? And he said, well, I'm at a bus stop. I thought that I could get from my home to my office soon enough to be in my office, but I couldn't get there, and I'm here at the bus stop. I said, I'm very sorry, but we'll have to reschedule this session because I don't think it's a good circumstance. First of all, people here in New York are not supposed to be outside more than is needed. You might not have the appropriate distance from other people. I don't see how you could feel comfortable discussing very personal things in that setting. So I had to insist that, and this was at a little bit of a sacrifice, but I'm willing to do it because, you know, I had set that hour to have the session with him, but without charging him, I said, let's find a time tomorrow, but I have to insist that you are in a place where you're not in a public space, there's privacy, you can feel comfortable talking. We have to be somewhat forceful about this. Some of our patients said, I don't want to have the online sessions. I want to see you in person. I'm paying for that. I have the right to that. And we say, we're sorry. The same way we feel we represent reality in general to patients when the patients might be having a kind of an odd response to the situation they're in. We say, this is a situation where we are mandated to do something. And interestingly, Ilaria, that brings us to the issue of safety. We're very concerned. That's part of our frame of treatment. If a patient, now I'm digressing just a bit, if a patient is sexually active, are they practicing safe sex? That's something we would go over with any patient. All the people I've been talking to in my group are doing a kind of a checkup. Are our patients being safe around the coronavirus, or are they not following the regulations and the guidelines? So we find that as we set up this frame in the new circumstance, we're checking about safety issues the same way we would check about other safety issues in other less unusual times. Because a person can act out in this situation in the same way they could act out in other situations previously. Are they being in denial? Are they taking risks? Do we have to set limits around that? shall we interpret that? You told me about a patient who didn't have a private space in their apartment. That's a problem. We try to make sure people can be isolated enough where they're living so they feel comfortable speaking freely. But maybe that's not true for everybody. You
Yeah.
said your patient went to their car. That might, I mean, I hadn't thought of that. That might be an adequate solution. It's odd, but that might be the only place they feel comfortable, feeling they can communicate and not worry about being overheard.